This is a pre-recorded presentation, so the presenter will not be taking any questions. However, all questions asked during the live presentation, along with answers, are included at the end of this presentation. To learn more about our upcoming patient and family conferences in your area, please visit aamds.org/conferences. To view other recorded presentations or to register for other live online learning events, please visit aamds.org/learn.
Welcome to our live webinar titled Understanding Your Complete Blood Count and Your Bone Marrow Biopsy Results. Thank you for joining us today. My name is Lee Clark, and I'll be moderating the presentation. As we get started, I would like to thank the generous support of our patients, families, and caregivers for providing support for the webinar program. Today's presenter is Dr. Casey O'Connell. She is an associate professor in the Division of Hematology at the Keck School of Medicine, University of Southern California. She did her undergraduate work at Stanford and completed her medical degree with distinction at the George Washington School of Medicine. With that said, it is my pleasure to welcome Dr. O'Connell.
Thank you, Lee. It's great to be here. So today I'm going to try to go through the complete blood count report with you, as well as the bone marrow biopsy reports that you may have read through or are anticipating, and help you generate good questions to elucidate what's happening when you're with your physician. So the outline of the talk will be, we'll start with what is included in the CBC and talk a little bit about red blood cells, white blood cells, and platelets, and what the CBC tells us about those cell types. Then we'll move on to the bone marrow aspirate and biopsy, what's involved, and what is included on the report. So, as you probably know by now, the complete blood count is generated from a small tube of blood that is usually drawn in a phlebotomy lab at your doctor's office or in a lab somewhere. And the blood is collected in a tube where we can see the fluid aspect of the blood, also known as plasma, that will separate out from the cellular aspect of the blood, which contains mostly your red blood cells and a small layer of white blood cells and platelets. There's a machine that most laboratories worldwide use to generate the complete blood count from that small tube of blood, and it's called the Coulter counter, currently distributed by the company Beckman Coulter. So the Coulter counter works on a principle that was originally discovered by Walter Coulter, where essentially the little tube of blood that I told you about, they put the cellular part into a container that has some electrical flow in it. And as cells pass through a teeny tiny hole, they exert a certain amount of impedance against that electrical current. And this results in generation of certain numbers of cells based on that electrical impedance. So just a simple concept, a little hard to explain. You don't need to know too much about that. But what that will come out as is a printout called your complete blood count. It looks a little bit like this, with the components listed here, including the WBC or white blood cell count, and then these items here related to your red blood cell count. Then there are several we'll talk about later that have to do with what the red blood cells look like, the platelet count, and then the MPV has to do with the size of the platelets. So that report will generate a result for you and then a reference range or a normal range for you to compare your results against. These are the units for which each of these cell types is expressed. So we're going to start our talk off by focusing specifically on what the CBC tells us about our red blood cells. So there are 3 items on the CBC that tell us about the quantity or how many red blood cells do we have. They are the red blood cell count, the hemoglobin, and the hematocrit. So the red blood cell quantity measure, known as the red blood cell count, is an absolute number of red blood cells in a small volume of blood. So it's really just counting the individual cells regardless of their size or what's inside of them. The second measurement related to our red blood cells comes out as what's called hemoglobin, or abbreviated HGB. This is the amount of hemoglobin in a given volume of blood. And so hemoglobin, as you can see in this insert here, is this small twisty protein which is living on in our red blood cells and is responsible for carrying oxygen around via these red blood cells. So you may have heard of people being iron deficient. Hemoglobin is where this iron sits in order to carry the oxygen. So if you don't have enough hemoglobin, then you may not have enough oxygen delivery to the cells of the rest of the body, and this can lead to symptoms such as fatigue or shortness of breath. The third important red blood cell quantity measurement is called the hematocrit, or abbreviated HCT. So this is the percentage of red blood cells in a certain volume of blood. So the first one was the red cell count, absolute number. The second was the hemoglobin, which is the protein contained in the red cells. And this third number refers to a volume of red cells as it relates to the whole blood. So you can see here from that original tube of blood I showed you that the amount of red cells as a ratio to the whole volume here is almost 50%. So indeed, a normal hematocrit, or HCT, is about 45% in a normal person. So when it comes to red blood cell quantity measures, there's a couple of things you should know. So first of all, generally speaking, the red blood cell count, hemoglobin, and hematocrit, those three quantity measures, they tend to move together. So they will increase all three of them together or decrease all three of them together in most situations. So most physicians do not refer to the red blood cell count. Generally speaking, physicians will pick one or two of those three quantity measures and use those to follow a patient. So it's good for you to talk to your doctor about whether he or she wants to follow, let's say, the hemoglobin, or are they more comfortable following the hematocrit, so that you can decide on one and the two of you can sort of speak the same language, so to speak. So normal values can range between laboratories. So a patient may come and see me and find out that their hemoglobin is a bit low at 10, and then at another doctor's office a week later, the hemoglobin shows up at 10.4. In my mind, the difference would be negligible between 10 and 10.4 since this was done at two different labs. A normal hemoglobin would be 12 to 15 grams per deciliter, and a normal hematocrit is going to be somewhere around 40% with a range of 36 to 46%. So again, if you pick one of these values and then follow that consistently, you and your physician will be speaking the same language. Just for reference, hemoglobin values that drop below 7 or hematocrit below 21 can be dangerous and may require a blood transfusion. But it's important to discuss what level your physician is going to recommend a transfusion, and also to report what symptoms you're having at different levels of hemoglobin so that you and the physician can decide a level for transfusion that is most appropriate for you. The next set of measures on the complete blood cell count refer to these four items here, which tell us all about the quality of the red blood cells. So not so much the quantity, but the quality. What do they look like? We also refer to these as red blood cell indices. So the first we'll discuss is called the MCV, or mean corpuscular volume. This refers to the size of the red blood cells, and the normal size is expected to be 80 to 100 femtoliters, or FL, abbreviated here. A low MCV can occur when cells are iron deficient, and sometimes also when they're copper deficient, or have less hemoglobin for some other reason, like sideroblastic anemia, a form of myelodysplastic syndrome. An elevated or high mean corpuscular volume, MCV, can result from certain medications like hydroxyurea or methotrexate, from B12 deficiency, and we also see an elevated MCV frequently in aplastic anemia and MDS. Here's just a little cartoon showing here a red blood cell that looks a lot smaller than this normal guy here, and indeed this red blood cell has an MCV of less than 80. This normal-sized red blood cell has an MCV of 80 to 100, and then this larger size, also known as macrocytic red blood cell here, has an MCV of greater than 100. The following red blood cell indices are probably less important in terms of following along with what's happening with your CBC, but I'd like to just explain them to you so you know what they are. So the first two are the MCH and MCHC. So these refer to the mean corpuscular. The corpuscle is another term for the shape of the red blood cell, and the H stands for hemoglobin. So mean corpuscular hemoglobin, meaning how much hemoglobin is in each cell. And this is very important in certain conditions that we make a diagnosis of. For example, patients who have thalassemia may have less hemoglobin in each cell. So we do use the MCH and MCHC when we start working up a patient with anemia, but once you know your diagnosis, it's usually not terribly helpful in terms of following along. Similarly, the RDW, which refers to red cell distribution width, essentially just measures the degree of difference or the degree of variation in the size of the red blood cells in the patient. The normal RDW is usually 12 to 14, and that indicates that most of the cells are about the same size. When the RDW is elevated, this suggests that there are lots of different sized cells around, and we can see that in conditions such as iron deficiency and some forms of myelodysplastic syndrome. Again, it's not usually helpful following the RDW once you know what the diagnosis is for the anemia. Turning back to other elements of our CBC, we're now going to talk about the white blood cell count, which is abbreviated WBC here. And we see the normal range is 4.5 to 11. For this particular patient, it's normal right in between at 6.7. So what does the WBC tell us? It tells us the total number of white blood cells in a given volume, and that total number is going to include all subtypes. And you can see the subtypes of the white blood cells in the cartoon down here. So we have neutrophils, which usually make up most of the white blood cells. We've got eosinophils, which are important if you have an allergic situation, basophils, monocytes, and lymphocytes. So the total white blood cell count is going to give us the number of all of these white blood cells combined. We may see an elevated white blood cell count in infection, and it can be low or elevated in MDS. It's usually low in aplastic anemia. The white blood cell count is often broken down for us so that we can see the individual subtypes, and that is reported as something called a differential, or we'll sometimes shorten it and use the term Diff. So here you see the different subtypes of white blood cells that I mentioned, and then the absolute values that are in the normal range. They're also reported usually as a percentage. So again, if you are interested in following, for example, the neutrophil count because you found out that that was low, you are going to want to pick probably an absolute value to follow. You can figure out the absolute value by multiplying the percentage times the total white blood cell count that's reported on the CBC. The reason I bring up those neutrophils is that they really are the most important white blood cell subtype for fighting infection. Doctors will often refer to something called the ANC, or absolute neutrophil count. If a patient has more than 1,000 absolute neutrophils, we're generally not terribly concerned about a high risk for infection. That risk does increase if the neutrophils are lower, such as between 500 and 1,000. The risk is very high for infection in patients who have fewer than 200 neutrophils on their absolute neutrophil count. In MDS, neutrophils can look a little funny. We'll talk about that later. They can have extra lobes and be called hypersegmented, or not enough lobes and be called hyposegmented. The reason I point this out is that if the laboratory performed what's called a manual diff, meaning they did the breakdown of the white cells by hand, they may make a comment that they saw hyper or hyposegmented neutrophils on the report. So the last category on our complete blood count is the platelet count. So the last two items refer to the number of platelets or platelet count, as well as to the size of the platelets, which is abbreviated MPV, mean platelet volume. So the MPV is not terribly consequential. The platelet count, of course, is important, and in normal situations, it's between 150 to 400 times 10 to the third, or it might use the letter K, which means thousands, per MCL. It can be low or high in MDS, but is usually low in aplastic anemia. The platelet size tends to be normal and sometimes large in these disorders. Small platelets really don't have any clinical consequence if the number of platelets is normal or high. So don't worry if the MPV says it's quote-unquote low. Here we see some platelets, which are these purple dots here, and these are on what's called a peripheral blood smear. And here the arrow is pointing to a really large size platelet. So that may result in a CBC that reports a high MPV, or mean platelet volume. Again, if you're already carrying a diagnosis, the MPV will not have a whole lot of meaning in terms of the follow-up. So let's summarize the CBC for MDS, what to focus on. The white blood cell count, if it's rising, can be a concern, especially if there are blasts reported on the differential. This could indicate that the disease is becoming more aggressive. If the white blood cell count is very low, especially when the absolute neutrophil count is below 0.5 times 10 to the third, or 500 per microliter, this can increase the risk of infection, or could be a result of having been treated and could recover after a couple of days or weeks. For patients with MDS, the hemoglobin and hematocrit usually can cause symptoms like fatigue or shortness of breath if they're below 10 and 30 respectively. As I mentioned, if the hemoglobin drops below 7 or 8 or the hematocrit below 21 to 24, a physician may recommend a blood transfusion, particularly in symptomatic patients. Lastly, in terms of platelets, normal was 150 to 400,000. If the platelets are running between 20 and 100,000, or 20 to 100 times 10 to the third, generally we do not offer any particular intervention, but we do suggest that patients be careful and avoid trauma or falls, as the bleeding risk does increase at lower levels. Physicians may recommend a transfusion if you're actively bleeding or the platelet count drops below the 15 to 20,000 range. Now, for patients with aplastic anemia, the important things to note aren't too different, although the rising white blood cell count with blasts is generally not an issue of concern. A low white blood cell count, especially with that ANC being less than 0.5 or 500, can increase the risk of infection, may be the result of treatment, and can sometimes recover. But some physicians will place patients on antibiotics to help prevent infection if the white count remains this low. Just like in MDS, if the hemoglobin and hematocrit are below 10 and 30, the patients may feel more symptomatic, and at some threshold, the physician may recommend blood transfusion. Lastly, you should watch your platelet count and notice if it's between 20 and 100,000 but there's active bleeding, the physician should be notified, although generally no intervention is indicated unless the count is below 15 to 20,000. Okay, so that wraps up our topic of CBC reports. Now we're going to move into the bone marrow biopsy and aspirate. So the bone marrow biopsy and aspirate are a procedure that allow us to take a look deep inside the bone marrow where the stem cells give rise to the early blood cells. In order to get into that space, we have to use a needle that's large enough and hard enough to access it. This is a picture of the Jamshidi needle, which you may have already experienced. It has a little inner piece that can be taken out in order to take our sample from the bone marrow. Most adults make their blood primarily in these hip bones, also called iliac bones, and femurs of their thighs. Since this posterior or backside piece of that iliac bone comes very close to the skin, it serves as a good place for us to perform a bone marrow biopsy when a patient has low blood cell counts. This is a picture of a patient having a bone marrow aspirate performed. In this particular picture, the patient is laying on his or her side. We sometimes do these in the supine position or face down position. In the subset picture, you can see that the bone has these compartments. The very outer part, the white hard part of bone, is called cortical bone. That doesn't have much blood production. We like to get into further below the cortical bone where we find the marrow cavity where these early blood cells are being made. And there are these little wisps of bone that lace around that marrow cavity. Here that's referred to as spongy bone, and we sometimes see that when we do the aspirate and call it spicules, or little pieces or flecks of bone. The bone marrow biopsy procedure usually has two aspects. The first is called the bone marrow aspirate. Now, in this part, we're just taking fluid, which looks a lot like blood, from that bone marrow. This is usually the more painful part of the procedure. The fluid that we take out contains those early cells that are about to leave the marrow. This fluid is very useful for us to perform techniques such as flow cytometry, cytogenetics, and morphology, where we take a good close look at the cells. If a patient has scarring in their bone marrow, also called fibrosis, we may not be able to take this aspirate. That's often called a dry tap. Here's a picture of what the bone marrow biopsy itself looks like. This is a firmer piece of what looks a little bit more like bone, also called a core specimen sometimes. We like for it to be at least 1.5 centimeters in length. Here you see this one is about 2 centimeters in length. The bone marrow biopsy is useful for assessing the cellularity, how much cellular action is going on in that bone marrow. We can stain it to see if there is indeed fibrosis, and we can see atypical groupings of cells, which sometimes provides diagnostic information. So now I'm going to move on to 6 important elements of the bone marrow biopsy results. The first that you may want to know and that you'll see early in the report is called the cellularity. This refers to the ratio of blood-forming cells to fat cells in the bone marrow. Normally, the cellularity is about 40%. Here's a picture of a bone marrow where the purple dots are all cells and the big white globules are all fat. This is a normal-looking cellularity of about 50-50 or 40-60, and we would call that normocellular. Now this is a bone marrow that has mostly fat. Very few cells are squeezed in between these globules of fat. These circular things that are pink are blood vessels. So this particular bone marrow looks very hypocellular or aplastic. In most cases of myelodysplastic syndrome, the bone marrow is actually hypercellular. So the bone marrow is trying very hard to increase production of blood cells, but is just not so effective at doing so. There are about 15% of MDS patients that have hypocellular bone marrows, and they may have a chance of responding to different therapies. In aplastic anemia, the marrow is always hypocellular or acellular or aplastic, and that's where the cellularity is less than 20%. Here, the cellularity is really less than 5%. Number 2. Are all cell types represented in the correct ratios? So, in the body of the bone marrow report, there will be some comment about whether the early grandparents of those blood cells out in the peripheral bloodstream are present or not. So the term myeloid usually refers to white blood cells, and erythroid refers to red blood cells. Normally, the ratio of those white blood cell precursors to the red blood cell precursors is about 5-to-1. If that ratio is off, that may help indicate the reason why one of the blood cell types is low. Megakaryocytes are the cells that give rise to the platelets. If the platelets are low, the normal bone marrow should respond by increasing the number of megakaryocytes in order to generate more platelets. In myelodysplastic syndrome, the megakaryocytes could be elevated or low, and aplastic anemia, they're usually low. There is a term called aplasia, which can refer to, or which refers to, absence of cells in the bone marrow. So for aplastic anemia, we don't see any cells at all. But sometimes there can be aplasia of just one type of cell. For example, you may see the term megakaryocytic aplasia, where there are no precursors to platelets present in the bone marrow specimen, or red cell aplasia, which is a subtype of aplastic anemia where only the red blood cell precursors are wiped out. Moving on to number 3, morphology. The term morphology tells us or indicates what cells look like to the pathologist who's looking at these cells under the microscope. In MDS, the cells don't look normal many times, and so this term that's used to describe abnormal-looking cells is called dysplasia. In aplastic anemia, if there are cells that can be seen, they usually look normal. So in this example, we see neutrophils, those infection-fighting white blood cells. Here we have a nice round cell with little tiny twisted lobes of nucleus. Here's another one. And then there's kind of purple dots or granules in the cytoplasm. In myelodysplastic syndrome, the nucleus here is not twisted and lobed the way it should be, nor is it in this particular cell here. So these are examples of dysplastic neutrophils. Number 4. The next question to ask about the bone marrow biopsy results is whether there are abnormal cells present, also known as blasts. There are 2 ways to count these blasts or early myeloid cells. They can be counted by the pathologist who stains or puts a color on the cells, usually CD34, or the cells from the bone marrow can be run through a machine called a flow cytometer that reads out how many cells have CD34 on their surface. Unfortunately, these 2 ways of counting blasts are not always exactly concordant. So there may be, under the flow cytometry, a reading of 8% blasts, and then under the manual count, or IHC immunohistochemistry, which is what the pathologist uses to see the blasts, a slightly higher count, like 10 to 15%, or maybe even a lower count, like 2 to 4%. We usually rely most on what the pathologist sees using the CD34 stain. But sometimes, if that stain didn't work or the pathologist is not sure, we may be left depending on the flow cytometry. Blasts are not typically present in patients with aplastic anemia. The number of blasts is very important in the prognosis of myelodysplastic syndrome. When the total blast count as a percentage of all the cells rises above 20%, this indicates progression to acute myeloid leukemia. Here's a picture of a blast cell. It's a big purple cell. It's got a dark nucleus with these little circles inside called nucleoli. And the pathologist can pick these up just by scanning the blood cells under the microscope. But of course, it's a little more objective when they use a special stain. Item number 5 that's important from the bone marrow biopsy and aspirate results are something called the cytogenetics. This is a special study used to determine how the genes look inside dividing cells. If there's been genetic damage, such as loss of a piece of a chromosome, the cytogenetics can usually pick this up. Patients with aplastic anemia will normally have normal cytogenetics, whereas about half of patients with myelodysplastic syndrome have something abnormal found on cytogenetics. A normal male will have a cytogenetic result of 46XY, and a normal female will have a cytogenetic result of 46XX. Sometimes we pick up important findings like deletion of part of chromosome 5. Patients with MDS who have this deletion may have special treatment options such as lenalidomide. There's a last and final report, which may or may not be present on your bone marrow biopsy, that is a form of what we're calling next-generation sequencing, also sometimes called myeloid mutation panels. These are additional studies that look for specific genetic changes or mutations that cannot be seen on routine cytogenetics. These are usually requested either by the treating physician who orders the bone marrow biopsy or by the pathologist who's reading the bone marrow biopsy, particularly if he or she suspects myelodysplastic syndrome. We now know that certain mutations are associated with certain morphologic or physical changes that we see in those blood cells, such as the mutation SF3B1, which is associated with sideroblastic anemia. This is a feature of the bone marrow where we see little iron granules trapped in developing red cell cytoplasm. Other mutations picked up on next-generation sequencing can confer a poorer outcome or even possibly modify treatment options, such as when a P53 mutation is identified. Unfortunately, we still don't have a lot of actionable items that we can use this next-generation sequencing panel for, so not all insurances or institutions have approved them being routinely performed. So in summary, what do you want to ask your doctor about your bone marrow biopsy? Here are the 6 topics we just discussed. Number 1, how is my cellularity? Number 2, are all cell types present in normal numbers? So the white cell precursors, the red cell precursors, and the platelet precursors, or is something missing? Number 3, is there dysplasia? Number 4, how many blasts are there? Number 5, are there abnormal cytogenetic changes? And if so, what do they mean? And finally, number 6, if it's done, are there abnormal molecular mutations? And if so, what do they mean? It's been a pleasure giving this presentation to you. I hope it helps, and we're going to open it up for questions.
Great. Thank you very much, Dr. O'Connell, for the wonderful presentation. We have a couple of questions. Our first question actually is coming from Australia. This person said, thank you very much for providing these webinars. Is a blood film performed only if flow cytometry flags a perimeter outside normal limits?
So I think that they're asking whether the differential is performed. So, because there's 2 items that you're mentioning. So the first is you're saying if a complete blood cell count, CBC, indicates that a further evaluation needs to be done with something called a flag of an abnormal result. So some physicians and institutions will order the CBC with a differential. So it will give you the readout of what the different white blood cell subtypes are. Others will perform the CBC without a diff, but if the white blood cell comes back as flagged as abnormal, then the hospital or the laboratory may automatically result in performing a manual differential on that. The second part of the question mentioned the flow cytometry. So flow cytometry is slightly different. This allows us to see the little flags that are on the surface of different cells. A flow cytometry usually needs to be ordered specifically by the physician or the pathologist. So for example, if we do a CBC in a patient with myelodysplastic syndrome and suddenly the white blood cell count has gone from 4 to 24, this will be flagged as an abnormal white blood cell count. The differential will then come through and tell us how many neutrophils, lymphocytes, etc. If there's a high number of blasts, which are those, potentially leukemia cells, then a physician may want to say, hey, can you please run a flow cytometry and actually count and tell me more about these specific blast cells that were picked up on the CBC. Most laboratories will not go ahead and reflex to do a flow cytometry just based on an elevated white blood cell count or presence of blasts.
Thank you very much. Our next question is, what does clonal hematopoiesis mean? Yep.
Yes. So clonal hematopoiesis is somewhat of a new term that we've thrown around, although the concept is old. So clonal hematopoiesis means that we know that in our stem cell, in our bone marrow, we're born with a whole set of stem cells, and these stem cells are waiting around for our entire lives for the signal to give us new red blood cells, white blood cells, and platelets. We generally consider this to be done or happening in a polyclonal fashion. And what that means is I might call on stem cell A, stem cell C, stem cell L, stem cell X to start growing and proliferating and giving me more blood. And when a stem cell does get called on to give more blood, the first thing it does is it replicates itself. So it leaves one of itself behind, and then the other goes ahead and differentiates into normal blood cells. With clonal hematopoiesis, we begin to have only one or a couple stem cells giving rise to all of the blood in our peripheral blood. And this is often a sign that there has been some kind of DNA damage or change where that clone of stem cells is now able to outgrow the other guys. Clonal hematopoiesis is not always an interchangeable term with myelodysplastic syndrome, but it can definitely evolve into myelodysplastic syndrome. We don't think that aplastic anemia is a form of clonal hematopoiesis because once we stop the immune attack on the stem cells, generally speaking, though not always, various stem cells are going to start popping up and getting called into action to produce blood cells once again. Hope that's clear.
Thank you. What is the normal cellularity on a bone marrow biopsy for children and teens?
Well, that's a very good question. So children and teens do tend to have a higher cellularity than most adults. So we're usually looking at somewhere in the 50 to 65% range for cellularity for kids, although there can be some variation depending on what's going on. So a child who does not have aplastic anemia, we would expect the cellularity to be in that 50 to 65% range.
Thank you. What is the difference between MDS and AML? Also, does MDS always progress to AML?
So that's a very good question and an important one. We think of MDS and AML as living on a spectrum. So if you go all the way to the left of the spectrum where the risk is very, very low, you can have clonal hematopoiesis where there are a few stem cells giving rise to most of the person's blood, and that may not even result in low blood cell counts at first. If that progresses to myelodysplastic syndrome, that can take up the whole middle part of the spectrum because there are some patients with what we call very low risk myelodysplastic syndrome, and they may never evolve into acute myeloid leukemia. All the way towards the right, higher risk end of the spectrum is acute myeloid leukemia, which is defined somewhat arbitrarily, simply as having 20 or more than 20% blasts in the bone marrow or the peripheral blood. So an MDS patient with high-risk disease, meaning high risk for developing acute myeloid leukemia, may have 15 or 18% blasts. The only distinction between them and a patient with acute myeloid leukemia is 3 to 5% blasts. So it is somewhat of an arbitrary cutoff. But lower risk patients with MDS may never evolve into acute leukemia.
Thank you. Is there a down regulation in ATM gene in idiopathic aplastic anemia?
I'm not exactly sure about the nature of that question. Idiopathic aplastic anemia is generally thought to be a benign condition where patients' T cells are attacking the stem cells. There are a whole variety of signaling defects that can occur both as a cause of that problem and as a result of that problem, and I can't say specifically about how the kinetics of the ATM or protein are affected. I'm sorry.
Thank you. And this person says your presentation was a delight. When reviewing cell counts, how do physicians determine if changes in cell counts are meaningful?
Yeah, so that's a very good question. One of the reasons for us to consider if a meaningful change has occurred is that we're using the blood cell, the CBC, blood cell count, as a surrogate marker, that represents what we believe is happening in the bone marrow. So patients will sometimes ask, should I have another bone marrow biopsy? But if the blood cell counts really haven't changed, then the answer is, well, the bone marrow biopsy is unlikely to show us anything new. On the other hand, if there has been a significant change, and I'll tell you what I mean by that in a moment, then we may want to do a bone marrow biopsy in order to pick up any additional information, such as a new genetic change that may have occurred or an increase in the blast cells that may have occurred. Now, in terms of what constitutes a significant change, so for me, there's no standard on this that we can read about somewhere and follow. So for me, if the patient has a change that requires a new intervention, so for example, the platelets drop below a range where I actually have to give a platelet transfusion and I wasn't before, or the hemoglobin drops to a range where I now have to give a transfusion and I wasn't before. Similarly, for the neutrophil count, if it was above 1,000 and now it's dropped, below or continues to drop, those would all be fairly significant changes that would prompt me to repeat a bone marrow biopsy. Now, as I mentioned, there is variation in between patients and between laboratories. So I usually like to see two different laboratories heading in a different direction before I'm prompted to repeat a bone marrow biopsy. So if, for example, the hemoglobin has been running 8.7 and suddenly I get a 7.9, I may want to repeat that next week and make sure, because if it comes back at 8.6, then perhaps the 7.9 was just a laboratory error. So I usually like to see two values that are both going, in a direction that I think represents a change, and then I'll recommend repeating the bone marrow biopsy.
Thank you so much. And our last question is, does eating or not eating before a CBC affect the results?
Eating should not affect the results of your complete blood count, no. So I know a lot of patients have gotten used to fasting before blood labs, especially for example, cholesterol panels. But technically, most of the labs that we do in hematology don't require fasting.
Great. Thank you so much. And that's all the questions that we had for today. So thank you very much, Dr. O'Connell, for the wonderful presentation today and for taking the time to be with us. I'd like to add that if you'd like to rewatch this webinar at a later time, please be on the lookout for an email that will provide you with the archived link within 4 to 7 business days. On behalf of the Aplastic Anemia and MDS International Foundation, I would like to thank everyone for joining us today, making us your resource of choice for bone marrow failure diseases. If we were not able to answer your question today, please send us an email at help, HELP, at AAMDS.org so we can assist with answering your question. As a reminder, there will be a post-event survey which will pop up on your screen immediately following the presentation. We do appreciate you taking a few moments to complete the survey. Thank you for joining us. Remember, learning is hope. This concludes today's program.